I always start out by showing that I have no financial interests in cell therapy, and that's that's important because when you read editorials in high-profile journals regarding cell therapy, always keep in mind that many of the authors have financial interests in either promoting their product or denigrating a competing product. And so unfortunately, that's something that has been a problem in this field and continues to be a problem nowadays, but it's important to keep that in mind. So this is the Gartner hype cycle. It has happened over and over in any new technology, new field of research, and cell therapy is no exception. Cell therapy began at the beginning of the millennium, and very quickly everybody became very excited. And you could read on lay media and even on academic media very, very unrealistic expectations. But then we went through a trough of disillusionment and disappointment. And now I believe we are right here in the ascending slope where we are moving the field forward with more realistic and objective expectations. And I believe cell therapy, and let me say that at the outset, I believe cell therapy, even though it has been very controversial and it has had a very tumultuous life so far, it will eventually become a routine treatment for heart failure. But we still have a lot of work to go and a long way to go forward. So as an introduction, there are two kinds of stem cells, the pluripotent stem cells and the multipotent stem cells. The pluripotent stem cells are cells that can produce cells from all three layers, embryonic layers, the endocardium, the endoderm, the mesoderm, and the ectoderm. And the prototype of these cells are the embryonic stem cells obtained from the inner mass of the blastocyst, as well as the induced pluripotent stem cells. Now, the adult stem cells are not pluripotent, are multipotent, meaning they can generate cells that belong to one layer, embryonic layer. For example, the mesenchymal stromal cells, which are going to be the main topic of my talk today, can generate cells from of mesodermal origin, meaning they can produce fat, bone, cartilage, tendon, and fibrous tissues in general. Hematopoietic stem cells can generate blood cells, of course. Now, let's spend a few minutes to discuss pluripotent stem cells. So there are two types, as I said, the embryonic stem cells and the induced pluripotent stem cells. Now, the embryonic stem cells have been touted in the media as a miraculous and revolutionary advance in the treatment of heart disease. But as often is the case in the media, most of what you read is either false or misrepresented. This is actually not the case. So let's do a reality check regarding the therapeutic utility of embryonic stem cells as a therapy for heart disease. There is a host of formidable problems. First, there are obvious ethical and regulatory issues because these cells require the destruction of a human embryo. Secondly, there is the risk of tumorigenicity after these cells are transplanted, and even though nowadays they're being differentiated to produce myocytes or precursors of myocytes, the transplantation of a large number of cells, we are talking about billions of cells that are being used, at least in primate studies, means that some of these cells may still be primitive, and all it takes to produce a tumor is theoretically one cell or at least few cells. So this is a risk that I think is going to be with us no matter what the efforts are to minimize the incidence of teratomas. These cells, in order to generate billions of cells, need to be cultured for a long time. And this, of course, provides opportunities for genetic abnormalities which may result in tumorigenicity. Since the cells belong to a different organism, the recipient will require lifelong immunosuppression, which is in itself a disease. And also, importantly, the main reason for using these cells has been the claim that once they are transplanted, they will survive and differentiate into new cardiac myocytes, in other words, regenerate the heart. So this, at the experimental level, this has never been shown. So there is no study showing that transplantation of either ESCs or ESC-derived myocytes results in formation of new myocardium at, let's say, 6 months after transplantation. So most studies have followed 1 month or less, and even at 1 month, there was less than 1% survival. And when the follow-up was longer than a month, 2 or 3 months survival, and less. There is no study showing long-term survival of planted embryonic derived myocyte in the heart. This is a study, I believe it's the largest study in primates so far that was published in research a few years ago. 44 monkeys were used, and they received human embryonic stem cell derived myocytes. They were heavily immunosuppressed. And as you can see, by 140 days, that's a little over 4 months, after transplantation, the cells were undetectable in the heart. Also, studies by Mary et al. Have shown a risk of ventricular tachycardia in primates that receive ESCs, which is not something you particularly like to do in patients with heart failure. And finally, we now have a very good alternative that does not have the ethical issues of embryonic cells, which are the iPSC-derived myocytes. And so it's not clear what is the reason, particularly for using ESCs when similar cells can be obtained from iPSCs. iPSCs are still work in progress. They may eventually find therapeutic utility, but there remains some really significant hurdles. First of all, it is very expensive to make iPSC-derived cells from each patient, and so financially that's not feasible. So maybe there could be allogenic iPSC-derived cells obtained from a donor, but that also is expensive, and so far that model has not really been worked out in clinical trials. Of course, they can also produce tumors because, just like embryonic cells, the iPSCs are primitive cells. And even though they are autologous, particularly actually if they are allogenic, but even in case of autologous cells, there has been some suggestion of possible immunogenicity. This is particularly relevant in the case of allogenic iPSCs, which may be rejected. So these issues still need to be worked out. I don't see iPSC-derived cells as a clinical therapy in the near future. They may eventually get there, but I don't think this is going to happen in the near future. So in the near future, the cell type that is most likely to become a therapy for heart disease are adult stem or progenitor cells. What I would like to do now is to summarize as best as I can and as objectively as I can What we have learned in the last 20 plus years since the dawn of the areas of cell therapy for heart disease, and try to correct several misconceptions and the excessive negativism and pessimism that unfortunately is plaguing this field. So let's start at the preclinical level. What we have learned is that many, but not all, different cell types are beneficial to the injured or failing heart. By beneficial, I mean that they improve left ventricular function. Now, this has been shown literally hundreds of times in many different animal models, in mice, in rats, in pigs, in even cats, and primates, and it is no longer arguable. This has been shown by many different and independent laboratories using many different cell types. So there is no question that transplantation of adult cells in the injured heart improves left ventricular function. Not all cell types, though, because there are some who say it doesn't matter what cell is used, they all work. That's not true. There are studies, and we have done several, where certain cell types are not effective and others are effective. But the idea that cell transplantation can improve left ventricular function is no longer a matter for discussion. Now, many so-called adult stem cells are not really stem cells, but a stem cell is defined as a cell that is self-renewing and is capable of differentiating into one or more cell types. Now, this has been shown in some cases, but in other cases, it does not. So I personally don't like to use the term stem unless the author or the investigator shows that the cell product is capable of differentiating into other cell types and self-replication, which in most cases is not the case. So I prefer to use the term cell to avoid any misconception. Perhaps the most important advance in the last 22 years has been the recognition that transplanted cells, regardless of the type used, do not engraft in the heart and do not form new cardiomyocytes. Now, this has been a sea change because in the early 2000s, we all thought, including ourselves, that transplanting cells in the heart will result in engraftment and formation of new myocytes and regeneration of the heart. Well, that turns out to be not the case. We were the first lab to show, for example, that the c-KIT positive cardiac cells, or CPCs, do not engraft in the heart after they are transplanted. This is a paper we published 14 years ago, or 13 years ago, in 2010, in which basically we had a rat model of chronic heart failure. We transplanted EGFP-labeled CPCs, and after 35 days, only 1% of the non-infarcted myocardium was EGFP positive, and yet LV function was improved. In other words, function was improved even though the cells had basically disappeared, had not engrafted. We then followed up in a more quantitative manner by measuring with real-time PCR methodology using male cells into female mice, measuring the number of CPCs that were actually present in the heart after transplantation, and this was published 9 years ago. And as you can see, after intramyocardial or intracoronary delivery of CPCs, of 100,000 CPCs, the number of these cells drops precipitously, and at 35 days, there are only a few hundred, maybe 1,000 left out of 100,000, which was the initial amount, and yet function was improved in these mice. So again, this study shows that CPCs do not engraft and do not differentiate into cardiac myocytes. Therefore, the phrase cardiac regeneration should be avoided. Instead, we should be speaking of cardiac repair, not formation of new muscle, but improvement in the structure of the heart or repair of the structure of the injured heart, resulting in improved function. So how do then cells work if they don't engraft and they do not differentiate into myocytes? So we now have learned that all transplanted cells, including the embryonic cells, work via paracrine or endocrine mechanism, because it turns out that these cells are true veritable factories of paracrine things. They release non-coding RNAs, growth factors, cytokines, bioactive lipids, extracellular vesicles, and so on. So that is the mechanism by which, and these factors can be released in the adjacent tissue in a paracrine fashion, or even in the bloodstream, so that they can act as a distance from the site in which cells are present. Now, the obvious question is, what exactly are these factors and what do they do? That's the single most important unanswered question in cell therapy. And unfortunately, today, the precise nature of these mechanisms is still unknown. The leading hypothesis at the moment is that cells work by inhibiting, at least in heart failure, by inhibiting the chronic inflammatory process that characterizes chronic heart failure. Cells also have anti-fibrotic actions, anti-apoptotic actions, and pro-angiogenic actions. So all of these could contribute to the functional benefits of cell therapy, and a lot of work will have to be done to sort this out. As I said, the prevailing hypothesis at the moment is that cells, particularly mesenchymal stromal cells, work by inhibiting inflammation. We have found this to be true also with c-KIT positive cells. This was a study from several years ago where we found that injection of CPCs in rat hearts, they were in chronic heart failure model, resulted in a decrease in CD45 positive cells, i.e. inflammatory cells, both in the risk region and in the non-infarcted region. But there are many other studies showing the same finding. We also found that another kind of cells, the cardiac mesenchymal cells, which are basically MSCs isolated from the heart, in vitro have very significant anti-inflammatory effects when they are co-cultured with macrophages. They markedly inhibit secretion of TNF-alpha, interleukin-1, interleukin-6, and other cytokines. And there are, again, many other studies showing the anti-inflammatory effects of various cell types. Now, the second corollary, so the first corollary of the lack of engraftment is that cells work by paracrine or endocrine action. The second one is that because cells disappear rapidly, then repeated doses may enhance their therapeutic actions, right? Because it's just like a drug. You give a drug, it's metabolized, disappears, you need a second dose in order to maintain the effect. The same concept applies to cell therapy. So we did a lot of work in this area of repeated cell administrations. That's one of our papers from 2016, where we had a rat model of chronic heart failure induced by myocardial infarction. We allowed these animals to recover for 30 days. So now we had a stable scar. And then we gave 3 doses at 35 days intervals of either placebo or 1 dose of CPCs and 2 doses of placebo or 3 doses of CPCs. And then we sacrifice the animals at 35 days. And looking at the effect on ejection fraction in this chronic heart failure model in the rat, in the vehicle group, the AF was continually going downhill, which is the natural history of heart failure in this rat model. In the group that received a single dose, there was an improvement after the first dose, and then it leveled off, no further improvement until the end. But in the group that received 3 doses, the EF continued to increase after each treatment, so that at the end of the study, the total improvement was almost triple that which was seen after a single injection. So there was a cumulative effect of multiple cell doses compared to a single dose. So because of this, when we are looking at the efficacy of cell therapy, we must keep in mind that efficacy cannot be evaluated on the basis of a single cell dose. It really does not make sense to give one single injection and expect that to have the optimal effect on heart failure. Proper evaluation requires repeated doses. Now, almost every study done so far has used a single dose of cells in animal, and every study in humans has used a single dose. And that's something that most individuals don't realize. And they conclude that a cell product is ineffective when in reality, in my opinion, the efficacy has not really been tested properly because it has been based on a single dose. Now let's move to the clinical arena. What have we learned at the clinical level? So first off, it has been very unfortunate that most clinical trials of cell therapy in heart disease so far have focused on patients with STEMI, with acute ST segment elevation myocardial infarction. In that setting, there is no evidence of efficacy. There have been many studies. I wrote an editorial a couple of years ago in the European Heart Journal to point out that after the BAMI trial, which was the largest trial of cell therapy in STEMI, which was inconclusive, basically there is no point in continuing to study cell therapy in STEMI. It is not either not effective, or even if it is effective, the effect is so small that it can never be proven, because the prognosis in STEMI now is excellent, even in the absence of cell therapy, thanks to revascularization. And so basically, there is no point in continuing to investigate cell therapy in this setting. But because of the failure to show benefit of cell therapy in STEMI, the uninformed readers and observers and the enemies of cell therapy have concluded that cell therapy does not work, period, which is not true. So we must distinguish the setting of STEMI from other settings where cell therapy actually has promising results. And these are very different from the setting of STEMI. So one of them is refractory angina. This is angina that cannot be managed either surgically or interventionally or medically. It's a big problem. And in this setting, CD34 positive cells have shown very promising results in randomized double-blind studies. I don't have time to address it, and it's not really germane to the topic of my talk, but just want you to be aware of this fact. And of course, in the topic of this talk is heart failure. In this setting, cell therapy does have promising results, as I show you in a second. So the problem is that many people have conflated acute MI with chronic heart failure. And since there is no evidence of efficacy in acute MI, they have extrapolated that lack of efficacy to chronic heart failure, which has been unfortunate. So these are the cell types that have been or are being tested as therapies for heart failure. I listed at the top the ones that I think are not likely to become a therapy. The skeletal myoblasts have been basically abandoned. The cardiosphere-derived cells have not shown any efficacy in the ULSAR trial, and I don't believe are being tested in chronic heart failure anymore. The bone marrow mononuclear cells, unfractionated, are also basically abandoned, and the embryonic stem cells we already discussed earlier. What I want to focus the rest of this presentation is on the three cell types at the bottom, which are being actively investigated: the bone marrow mesenchymal stromal cells, the adipose-derived MSCs, and the c-KIT-positive cardiac cells. The mesenchymal stromal cells are the most important cell type that's being tested now in heart failure. They can be easily grown. They have a fusiform appearance, as you can see here, when you culture them in vitro. They are found in almost every tissue, including dental pulp, fat, umbilical cord, and of course bone marrow. They are rare cells in the bone marrow. They are one every 10 to 15,000 cells. In the blood is one every 100,000 cells. They are defined by cells that when cultured in vitro can adhere to plastic and are positive for CD105, CD73, and CD90. The MSCs are negative for hematopoietic markers such as CD45, CD34, and endothelial markers such as CD31. They are multipotent. In vitro, they can differentiate into cells of mesodermal origin, including bone, cartilage, tendon, fat, and fibroblasts, but they do not differentiate into cardiac myocytes, even though there have been some reports in the 90s about differentiation in cardiomyocytes. They have not been really confirmed. Now, why are we interested in MSCs? They have several properties that make them very interesting and very suitable for cell therapy in heart failure. First of all, these cells are true factories. They produce a lot of paracrine factors and have powerful, therefore, powerful paracrine actions. They produce anti-inflammatory, anti-fibrotic, anti-apoptotic, and pro-angiogenic factors such as cytokines, growth factors, microRNAs, bioactive lipids, extracellular vesicles, MMPs, and other molecules that affect the matrix, as well as they can modify adjacent cells by cell-to-cell contact by, for example, transferring mitochondria. Now, MSCs are well known to have very potent immunomodulatory and anti-inflammatory actions. For example, they produce the anti-inflammatory cytokines IL-4, IL-10, IL-13. They produce PG2 and IDO, which then in turn can polarize a macrophage and induce the M2 phenotype, which produces IL-10, and many other things. So the actions of MSCs on the immune system have been studied for a long time. They're being used, for example, in graft versus host disease because of their immune suppressive therapy and properties, And so they're very well established. And these actions could be beneficial in heart failure where there is a chronic inflammation as one of the driving factors of the progression of heart failure. The other interesting property of the MSCs is that they are immunoprivileged because they don't express the MSC class 2 antigen or the co-stimulatory molecules CD40, CD40 ligand, CD80, and CD86, which means that they're not rejected. So even though they're allogenic, they are tolerated by the immune system and they can escape rejection. So these properties make them really very, very interesting candidates for cell therapy for the heart. This figure here shows that they affect basically all components of the immune system, neutrophils, macrophages, dendritic cells, B and T cells, and they suppress the activity of all of these components. So the other interesting thing that we have learned is that MSCs are superior in terms of cell therapy for heart failure, are superior to bone marrow unfractionated cells. So initially, we started out with mononuclear unfractionated cells. This was in the early 2000s. But then we realized that MSCs are actually a better product compared to the unfractionated cells. And it was Dr. Hare that actually led to this advance. This was his trial TAC-HFT from 2014, in which he compared head-to-head the bone marrow MSCs with bone marrow mononuclear cells. And although both of them improved quality of life, there was an improvement in walking distance, in exercise capacity, the functional capacity in patients only with MSCs, but not with bone marrow cells. and there was a reduction in scar size only with the MSCs, but not with the mononuclear cells. So this was the first study that actually pointed out the superiority of MSCs versus the unfractionated cells. And by the way, in this study, the improvement in walking distance occurred despite no improvement in ejection fraction of LV volume, suggesting that functional improvement, functional capacity improvement does not necessarily require an improvement in ejection fraction. So this study, as I said, was the first evidence, and today the only one actually head-to-head comparison of MSCs versus unfractionated cells, and contributed to the use of MSCs in subsequent studies. So these are the trials, the randomized double-blind trials of the 3 cell types I just mentioned: bone marrow MSCs, adipose MSCs, and c-kit cells. As you can see, the early studies were using autologous cells, and the most recent study, allogenic cells. So this has been another advance we have made over the last 20 years, the realization that allogenic products are superior to autologous products because they, for several reasons, right? First of all, they are financially less expensive because you can isolate bone marrow MSCs from a donor and then expand them and use make billions of cells and use them for many patients. Secondly, the cells can be obtained from healthy donors, young healthy donors that don't have all the comorbidities of patients or the effect of aging on the MSCs, which certainly impairs their ability. And thirdly, the use of a single donor means that the cell product is more uniform compared to isolating cells from every patient, which obviously will not be a uniform cell product. So nowadays, basically, every new clinical trial is using allogenic cells, not autologous cells. So I already spoke about TAC-HFT. X-Myelocell was published in 2016 in The Lancet. It was a phase 2b study, 109 patients comparing the cell product, which is a mixture of MSCs and macrophages from bone marrow, with placebo. There was a 37% reduction in cardiac events, even though there was no change in ejection fraction. Now, again, these are all double-blind, randomized clinical trials. The MSC-HF trial by Jens Kastrup in Copenhagen was a phase 2 study of 60 patients with autologous bone marrow MSCs or placebo. There was a significant reduction in end-systolic volume and improvement in ejection fraction at both 6 and 12 months after treatment. Now, what I want to spend the rest of my time is more recent studies, CONCERT-HF, DREAM-HF, and Seneca that use MSCs or CPCs. So the CONCERT-HF trial was a study supported by the NIH-sponsored Cardiovascular Cell Therapy Research Network. It was published in the European Journal of Heart Failure. And it was a phase 2 randomized, double-blind, placebo-controlled, multi-center trial of the NHLBI Cardiovascular Cell Therapy Research Network, or CCTRN, that investigated the feasibility, safety, and efficacy of autologous. Unfortunately, these cells were autologous because the trial was planned in 2011 or 12 before we realized the superiority of allogenic products. So the efficacy of autologous bone marrow MSCs and cardiac c-kit positive cells, or CPCs, in patients with ischemic heart failure. Now, the oversight was enormous. There was oversight by the NHLBI, of course, by the 7 IRBs of the 7 clinical centers and the central IRB, by the Data Safety Monitoring Board, and of course by the FDA. This was arguably one of the most rigorous trials of cell therapy to date, if not the most rigorous ever conducted. The amount of controls and administrative oversight and checks was absolutely amazing. It took 10 years of work, was an enormous effort by 7 centers, 2 cores, a biorepository, a GMP cell manufacturing facility in Miami, the data coordinating center, and the NHLBI. Truly an amazing effort. So briefly, we studied 125 patients. The average ejection fraction was at baseline 29%. And these patients were randomized 1:1:1:1 to 4 groups, either the combination of MSCs or c-Kit positive cells, CPCs, or MSCs alone, CPCs alone, or placebo. And the cells were injected by the transendocardial route using the NOGA mapping system, which is shown here. Basically, each patient got 20 injections of cells in areas that were of intermediate variability. So the unipolar voltage was between 4 and 7.5 millivolts, meaning there was a mixture of scar and viable tissue in these sites. There were no significant differences in ejection fraction, LV volume by MRI, scar size, peak oxygen consumption, 6-minute walking distance, or NT-proBNP levels. However, when we analyzed the heart failure-related major adverse cardiac events, which included overall mortality, hospitalization for heart failure, or exacerbation of heart failure not requiring hospitalization, when we analyzed the MACE using the intention to treat analysis method, we found a very marked and significant decrease in MACE in patients receiving CPCs alone in the green bar, or CPCs plus MSCs in the yellow bar. This decrease in MACE was driven primarily by a decrease in hospitalization for worsening heart failure. It's also interesting that the results of the S-treated analysis were similar to those of the intention to treat analysis. So several patients that were allocated to a treatment did not receive the treatment for various reasons. For example, the cells did not grow, they did not pass the qualifications to be released, and other reasons. So there were, in the S-treated analysis, there were 15 patients that did not receive any cell product, but were randomized and were followed anyway. And as you can see, the incidence of MACE in this group is very similar to that of the placebo group. So this again strengthens the idea that the reduction observed in the CPC group or CPC plus MSC group was a true reduction, because both of these groups show a much higher incidence compared to the CPC or CPC plus MSC groups. So the untreated group is similar to the placebo group and to the MSC treated group, whereas the two groups that receive CPCs alone or MSCs show a much lower incidence of MACE. So this is really a very, very significant finding. Now, the Cox regression analysis showed a hazard ratio of 0.2 with CPC alone and 0.26 with MSCs plus CPCs, all the way up to 1 year and more, even longer after transplantation of cells. Also, the quality of life measured by the Minnesota Living with Heart Failure questionnaire score showed a significant improvements. Remember, the lower the better. So a significant improvement both at 6 months and 12 months with the combination of MSCs and CPCs. So, in conclusion, the CONCERT-HF trial suggests that in patients with chronic ischemic heart failure on maximal guideline-driven terms, so remember, these patients were getting the best medical therapy available, A single administration of autologous CPCs or MSCs has measurable beneficial effects over the ensuing 12 months, namely a reduction in hospitalization for heart failure with CPCs and improvement in quality of life with MSCs. The best overall results were obtained by combining MSCs with CPCs. Neither CPCs nor MSCs improved LV function or reduced scar size. Now, this may seem really strange and counterintuitive that there is an improvement in MACE without improvement in LV function, but it's actually the same finding that was observed in XL-DCM, which I mentioned earlier, and in DREAM-HF, which I will discuss now in a second. So in concept, there was about a 77% reduction in MACE with CPCs. In DREAM-HF, about a 30% reduction, in XL-DCM, a 37% reduction. So all these three studies, phase 2 or 3 studies, randomized double-blind, show a reduction in cardiac events despite not there being a significant change in scar size of LV function. So DREAM-HF is the largest study of cell therapy in heart failure to date. It was just published this year. The lead investigator is Emerson Perrin at the Texas Heart Institute. There were 560 plus patients, 565, I think, patients that were randomized to either bone marrow MSCs or placebo, or placebo. And so the primary endpoint was the rehospitalization for heart failure. That was not achieved. There was not a significant difference, but we learned something very interesting from DREAM-HF. In patients with high sensitivity CRP, greater than 2.0, meaning patients who have who have a systemic inflammation, there was a reduction in the hazard ratio for death, myocardial infarction, or stroke of about 35%. Whereas in patients with high sensitivity CRP less than 2.0, they were not inflamed, there was no difference whatsoever. So what this study shows is that maybe in future trials of heart failure, cell therapy should be used selectively in patients who are inflamed, because in those patients, the anti-inflammatory actions of MSCs may be more pronounced and therefore lead to a beneficial effect, whereas MSCs may not have much of a benefit in patients who are not inflamed. So that's one other thing that we have learned that we need to keep in mind. Seneca was a phase 1 first-in-human study, again, randomized, double-blind, placebo-controlled, of allogeneic MSCs in cancer survivors with anthracycline-induced cardiomyopathy, also supported by the CCTRN. We studied 37 of these survivors. They were studied about 18 years since the diagnosis of cancer. These were patients that received anthracycline and over the years developed heart failure because of anthracycline. Most of the participants were females, and most of them had breast cancer or lymphomas or leukemias. Now, this was a small study, so efficacy was clearly not the primary endpoint. Primary endpoint was safety and feasibility, but of the 13 efficacy measures, 10 of them were numerically in favor of the allogenic MSC group, and you can see some of them here, but particularly the 6-minute walking distance and the MLF-Q score, the Minnesota Quality of Life score, questionnaire score, they were significantly improved by cell therapy, even though we are talking about very small group sizes, as you can see, 15, 14 patients per group. So this was an encouraging study that supports a larger trial of MSCs in patients with anthracycline cardiomyopathy, which, as you know, has a very bleak prognosis. I also want to mention the ongoing DCM2 trial that's led by Josh Hare in which we are studying the efficacy of allogenic MSCs in patients with non-ischemic dilated cardiomyopathy. All of the studies, by the way, that are shown so far are ischemic cardiomyopathy, except DREAM-HF, which included both ischemic and non-ischemic. Going forward, looking at the future, the two things that I think are on the horizon are intravenous cell delivery, which obviously is cheaper, simpler, safer than transendocardial delivery and can be done everywhere, basically in every patient, and also allows repeated treatments, which, as I said, are important in order to properly assess cell therapy. So let me conclude very quickly by recapitulating what we went over through in the clinical arena. What we have learned in the last 22 years is that administration of adult cells is safe. There has not been one single report of an adverse event caused by a cell product in itself. Secondly, the cell therapy is unlikely to be beneficial in acute STEMI. There are promising data with CD34 cells in refractory angina. In chronic heart failure, the MSCs are the most promising cell type at the moment. Bone marrow MSCs are superior to unfractionated bone marrow mononuclear cells, which have now been abandoned. And allogenic MSCs are superior to autologous MSCs, so autologous cells are now basically abandoned. In chronic heart failure, randomized double-blind placebo-controlled phase 2 or 3 trials suggest beneficial effect of MSCs at 1 year or longer after treatment. In DREAM-HF, the average follow-up was 3.5 years. This despite the fact that we still do not know the optimal cell type, the optimal dose, the optimal route of administration, and the number and frequency of administrations. We still are learning how to use this therapy. And to me, the fact that we are seeing an efficacy signal with a product that we still don't quite know how to use is actually cause for hope and optimism, because it is actually quite remarkable. So last year, Dr. Bromwald wrote an editorial in the European Heart Journal where he basically lamented the current lack of clinical trials of cell therapy for heart disease, and issued a call for action, essentially saying that heart failure is a lethal disease. We still don't have a cure, and we need to continue to investigate this therapy, which seems to be promising based on the trials that I just showed you. So what is needed to move the field forward is rigorous, well-designed, randomized, double-blind, placebo-controlled trials to conclusively assess the efficacy of cell therapy. The way forward is not by stopping research, but by doing good, well-designed, conclusive research. It is important to have an open mind, to avoid preconceived notions, and to let ourselves be guided by the evidence. I'd like to acknowledge the support of the CCTRN and the colleagues in the Institute of Molecular Cardiology that have done the work over the last 20 years, particularly Dr. Tang, that has done all the rat and pig studies in our lab. And finally, I would like to thank the Lord for giving me the opportunity to do everything I've done in my life and giving me the skill to pursue this field. Thank you very much.